Hello, everybody. I'm back. Dr. K.K. Agarwal, President, Heart Care Foundation of India and Confederation of Medical Association of Asia and Oceania. And you are watching Med Talks with Dr. K.K. Agarwal, 120th episode non-stop on COVID-19. Let's have the headlines of the day. The vaccine war continues. Pfizer says 90%, Sputnik says I'm 92, and now Moderna says I'm 94.5% effective. And now Bharat Biotech says I am also in the line 3. I'm 26,000 phase 3 clinical trial starts. In the next 2 months, we will expect every company, every country to come back and say, I am more than 90% better, at least in something. After 4 months, the number of new corona infections in the country reduced to less than 30,000 as per the Indian government ministry. The WHO has recorded 65 coronavirus cases, including at least one cluster of infections among its staff at its Geneva headquarters. If WHO is not spared, this corona is not going to spare anybody. Following adoption of a resolution at this year's World Health Assembly, for the first time, 194 countries committed to eliminate cervical center and set targets to be achieved by the year 2030. Let's go to the topic of the day. Lessons learned from COVID-19 so far in the world and also in India. And for that, I have no other person than Dr. Shiv Kumar Sareen. He's a director of Institute of Liver and Biliary Sciences. He has been the chairman of the Board of Governors of Medical Council of India, Padma Bhushan awardee, Shanti Swarup Bhatnagar awardee, Third World Academy of Medical Sciences International Prize, Most Distinguished Physicians from India award by American Association of Physicians of Indian Origin, the Gifted Teacher Award, founding chief editor, Yellow Ribbon Campaign promoter and originator, and a person who matters as far as COVID policy is concerned. I will also have in between bring in Dr. Kalra, the former CEO of NABH. I will bring him in between the discussion to talk about the same situation. So first of all, Dr. Sareen, my question is very clear. What are the lessons learned so far as far as this COVID is concerned at an international level and at a national level? But before that, I just want to show you some slides, which I would like you to talk about it. Now, this is a slide. If you see in this slide, this is the word picture. There is only one wave, and the wave is up, down, up, down, up. And the mortality initially was higher, but even now the mortality is higher. So the graph is something different. In USA, we are seeing the first wave because it hasn't become zero like Canada. Canada, we have seen really a second wave. In USA, it is the first wave which is coming and going. Brazil, Peru, Argentina, in South America, we have seen the wave is the same. In Africa, we can see mortality and number of cases are dependent on each other. In Australia, we have a second wave. In New Zealand, hardly any cases. In all European countries except Russia, Russia is showing a wave depending on mortality according to the wave. But France, UK, Italy, Germany, Spain, they are showing mortality is much lower in the second wave. Upper one is the wave, lower one is the mortality. India, we are seeing only first wave. This is only one wave. We haven't seen a second wave in India. But if you see in Karnataka, Tamil Nadu, Uttar Pradesh, Maharashtra, and Delhi, it looks like Delhi is having a third wave. So my question will be, is it really the third wave, or is it the only first wave which is showing variations in the first wave? Because there is no gap between the first and the second. It hasn't become zero as we have seen them in Europe. Bangladesh, Pakistan, Lanka showing the same. Lanka is conspicuous by its absence of cases. Nepal, Bhutan showing the same pattern. Bhutan, no deaths. China, Taiwan, Hong Kong, Korea, Japan are showing a different response because their cases are missing. I mean, they are not showing any type of a response, scattered cases here and there. So, China, Taiwan, Hong Kong, Singapore, South Korea. Then, when it comes to Thailand, Malaysia, Indonesia, they are showing the response like India. Iran, Iraq, Arabian, they are also showing the response like India. Japan is also showing a second wave. So, if I want to summarize one thing is that we are getting different types of pictures. One picture we are getting is China, Taiwan, Hong Kong, Korea. These countries are showing practically very low mortality. So, is it due to low inflammatory diseases in that country and absent of hypercoagulation in that countries? That's one observation. Second observation we are seeing is in the European countries where multi-system inflammatory disease is very high. They are showing a second peak, and in between the first and the second peak, there are 2 months when they had hardly any cases. And third pattern we are seeing is more the cases, more the mortality. These are like even America, even South America, African countries, Asian countries, more the cases, more the mortality. Mortality hasn't come down. Like to have your opinions.
You have done a very good analysis as always. Uh, we have few questions. First thing is, what have we learned? I think we have learned that this virus is smarter than our current thinking. And if you leave any loophole, it is not going to, excuse you. So the other countries, like the first lesson, if we had learned well from Wuhan, that the first lockdown was 12 weeks plus. Our first lockdown was a bit shorter. I think if we had another 4 weeks in the very beginning, we would have probably decreased our numbers. And they multiplied the R0 at a given time was nearly 6, the number multiplying numbers. Second thing is the change in the migrants and the way the people move to different far off places. Therefore, these two are big lessons that people in India especially has several countries like different religion, different ways of living. We should have prevented this. Now, whether Delhi has three waves or other parts of India have second or third wave is a very difficult question. Scientifically, wave does not mean total elimination. Wave only means that there was a descent and there is. So if it is less than zero point 0.5 or 0 means your numbers were 1,000 and they have gone less than 500, maybe there is a decline and the numbers have gone down. So Delhi did see numbers having gone down to less than zero point 0.5. So there is possibility that we did have a decline, whether it is second or it is third. But right now we are on the upsurge. So, what have we learned as far as scientists are concerned? As scientists, we have understood that more you diagnose, more you detect, the better you can contain. If we had done it earlier, maybe much better, the lesson would have been that we would have been able to contain how Korea, how New Zealand, how Australia, or other countries could do so well because they actually contained every single person, which we could never achieve. It's such a big country, it was not possible. So, in my opinion, that time of having containment or lockdown has gone. Today, who gets it, how he gets it is not even possible. You can't even know why your driver or his brother or somebody else has got it and from where. So, there is a community spread now. However, even the community spread can be contained to some extent if we are very careful. So, my message very clearly as a scientist or as a person working in this is now we have to be careful. The only way of protection, and which you have also said, and I would again repeat, is to have the mask all the time and no more eating together. We have residents who, after surgery and others, they have eaten together and the whole bunch has gone. In fact, they have infected the patient also.
So I will come back to one more thing is that predominantly the response of this virus is a viral response and then a host response. And in the host response, we have two options of a Th1 response, that is a thymus helper 1 response and a Th2 response. Wherever we have seen a mortality, the mortality has been replicative of hyperimmune response with inflammation leading to thrombosis and death. And if it is a Th1 response which is coming, which is a higher, can this explain that why the mortality in many countries is low? Because, say, for example, in America, you have hypercoagulable state, 5% population. In China, Singapore, we don't have a hypercoagulable state. And when I speak to the Chinese Singapore Medical Association, they says we are hardly any using anticoagulation in management of such cases. Do you think that in India can that be correlated with inflammatory bowel disease prevalence or other inflammatory disorders proneness leading to high inflammatory states in India?
See, India mortality is not very high if you compare to the global standards. It is not very high. The hyperinflammatory response syndrome, or which is a cytokine storm state, that is a very typical, response. Anywhere in the world, this will be younger people, more immunity, higher resistance to the viruses. They will certainly have, and I think the Th1 and Th2, they are both actually working very strongly. And that is the basis of your vaccine also. That is the way you stimulate your vaccine and have a good memory in that. So if we focus on to what we have learned that this virus has a cell which takes up, let's say it is taken up by cells which are NK cells, or it is taken up by T cells, won't give you B cells, which should give you the memory. However, either patient dies or B cells are unable to mature enough to give a good antibody response. Why 40%, 30% of the people never make high enough antibodies is not clear. But it is possible that the virus goes away faster. You know, you have flu. Every year people get the same flu or a variant of the flu and they never get antibodies. So this is a flu virus. So we have never had a successful vaccine for cold, common cold. So this is similarly that the virus disappears before the antibody response producing cells become mature and strong. So therefore, unless the virus persists and it does not leave memory cells, so the memory cells are not there to remember. When it comes second time, it will be able to give you a good memory. So I think what we need to know is to have understand which type of cells. Yes, you are right. The second infection may not be very severe. In fact, it is mitigated by some kind of body's resistance in the immunity. And that is what the basis would be of the vaccine also. If you have given vaccine and the vaccine produced by antibodies produced by vaccines go down, still the infections will be much less.
We are seeing some cases where the virus persists after ninth day. It may persist for few weeks or few even months. And we know that it is non-infectious. But we still don't have a proof that it is not pathognomic, that virus dead cells which are present. It indirectly means that the phagocytosis, pyroptosis, and phagocytosis is not effective in clearing that particular antigen, viral antigen. And so do you think that this persistence of virus in the body, which is a non-replicative dead virus, can still initiate multisystem inflammatory disease like illnesses in the post-COVID phase?
Not really. Once the virus is dead, I think that part is over. What is remaining is the CAR phenomena, compensatory adaptive responses of the body. The CARs is a separate phenomenon. But you have said a very important question: how long the virus can stay in some people, especially those who have fatty liver. Especially, I have seen people where 4 weeks plus the virus has stayed in the stool. So, very interestingly, some people are indeterminate. Virus is like CT value has gone to 30, and they also have antibodies which have come out. So, there is Whenever you have an indeterminate case or the person has started improving, the message would be do also antibody. In fact, doing antibody to me after 2 to 3 weeks is a very good thing. After 3 weeks, you have recovered. If you have made good antibodies, it is very good. If you had infection with symptoms of fever, cough, or strong or moderate COVID, then antibody response is very good, and I think it will last longer. So the more you insult, जितनी जोर से थप्पड़ मारेंगे उतना ज़्यादा response होगा. It is possible that though, and when we see for the plasma donation, believe me, for plasma donation, when we see almost 3 or 4 out of 10 have antibodies which are so low. Their IgG is 1 in 20, 1 in 24, and this is how हम तो ठीक हो गए. But ठीक तो हो गए हैं, but you haven't got enough antibodies. So those, we only take plasma where antibody of IgG is more than 640. And in fact, ideal what we now do is neutralizing antibodies more than 640, which is very good. WHO, FDA says neutralizing antibody above 1 in 80 is good, but we try higher. So who is the person who has given good response? Those who got a moderate or severe disease, and in them the virus stayed, and then they cleared it. So persistence of virus means there is an immune deficiency. This guy cannot make good and has probably a problem. These guys they have fatty liver, and maybe the B cells are not good enough.
So again, we have been analyzing data of the medical doctors who have died. So I'm giving some observations. One of the observation which came from the Mumbai group, and they said that their CT values of RT-PCR have been lower. That means they have high viral overload, unpublished data. So because they say that these are getting repeatedly exposed to people, so their viral load is more. That's one. Second thing is that when I'm analyzing these people, most of the deaths have been in GPs, not in the specialists. And almost like 600 something people have died amongst the doctors. And GPs are the one who are living in a one room, in a garage, practicing with a very high viral overload. So probably healthcare workers, initial deaths were responsible because of the high viral overload. That's one. Number two is most of the people are again 40 plus. Probably pot belly obesity is very common. Fatty liver is very common among doctors. If you see their abdominal obesity will be very high. They may be having some degree of interferon 1A alpha resistance that they are not showing a primary immunity. We feel that all healthcare workers and high-risk peoples should be started on oral anticoagulation much earlier, maybe on day 0. They should get if they show a cytokine response of a CRP more than 10 by day 3, they should be aggressively treated before they develop hypoxia, because the science says wait for hypoxia to develop to be aggressive. We say don't wait for hypoxia to develop. If you see CRP at any given time rising to more than 10 milligram per liter, these are the people who invariably will end up into a cytokine reaction. I'm not talking about storm. I'm talking about before storm. I'm talking cytokine reaction versus cytokine storm. So amongst high individual, at least I am following all my patients with dabigatran on day 1 if they are high risk. And instead of waiting for hypoxia to develop, give them like a prophylactic. And on day 3, get their CT done, or on day 3, if their fever is more than 101, or on day 3, if they develop a cough, or on day 3, if they have CRP more than 10, which means they have developed some degree of pneumonia. And at that time, we start giving them steroid earlier before they develop clinical hypoxia. Your comments.
Well, this is a very good personal experience, and I know that you have managed these patients very well. First, why mortality in doctors? I'll give you some very interesting data from ILBS where we do every month, all maybe 700 plus people working here, we do their antibody levels for last 4 months. From the beginning till about 3 months, 3 consecutive months, the antibody levels in doctors was about 2%, including those who are working in ICUs, including those who are looking to patients with liver and COVID. We have 16 beds for liver patients and COVID. We are not a COVID hospital, but none of the doctors, and they all go and visit, 2% or 2.4% had it. On the other hand, 7.6% of the nurses had it. 20% of the technicians were positive for antibody. But most amazing part was 26% of the general public, administrative, GDAs were positive. 1 in 4 GDA, like Delhi was having that time 23, 29%, we were having the same. And it was clear that those who were in ICUs and others were wearing N95 or maybe double mask. I actually therefore brought both the double because this is what we always use. We use a surgical mask and N95. We don't trust alone. You can get 1,000 virions through this from around. So that is still not 100%, and we don't have N99. So doctors are more cautious. They would not get the infection. But on the other hand, the general staff, the purchase and others, they would eat together and get infected. They will drink coffee, tea together. So this is what the general public is doing. So I think doctors, to say they are dying more because they are overweight or something, this is like general population. But yes, GPs may be less careful than specialists like you. That's a very clear message. Please, please, please be extra cautious. Don't think that you have to get antibodies by getting exposed. That's not acceptable. You don't have to die to live. This is not going to work. So don't die. You have to live. All my medical colleagues, remember, do not eat together. Do not speak without mask on. I'm in my room totally closed. Therefore, I have taken this mask off. Number two, giving steroids early. I agree if CRP levels, but I will not believe one if they are rising. Say this was 10 and it is going up, or IL-6 if it has gone nearly 7 to 10 times higher. And also if you find that D-dimer levels have increased, although D-dimer is not very reliable. So any doctor who is hypertensive, obese, or has fatty liver and is above 40 or around 40 plus, there is no harm in starting anticoagulants like Clexane or Dabigatran or whichever you want. Giving steroids, I think if 3 days have passed, but still the lungs are okay, it is debatable, and I'm not an expert pulmonologist, but I would say if it is less than 7 corad or so, maybe you can wait. But if inflammation is high with pneumonia, cough, like you are saying, I think giving steroids is a very good option. That is probably the only thing which works very well. And of course, remdesivir has some role, but don't know how much.
Some of the patients show different types of reactions. Some are showing classical response where the fever responds to, say, steroid. Some people steroid fever is not responding to steroid. There they respond better to mefenamic acid. You give them mefenamic acid, fever disappears. Some people are showing an increased polymorph reaction. Now, if I go to the cytogenetics, IL-8 will be polymorph response. IL-1 beta will be happy hypoxia, high ferritin levels. And when we go into the genesis of the cytokine, we find that colchicine, which is working as IL-1 beta. I'm talking about mefenamic acid, which is working at NLRP level, which is working at nuclear factor kappa B cells at that particular pathway. If you give a leukotriene at the level of LPA lipophosphase A and leukotriene level, you give them a montelukast as a leukotriene inhibitor. So if you attack from 4 different angles in an acute inflammatory phase, that means because steroid is only working at the level of PLA2, it is reducing tissue necrosis factor, tumor necrosis factor alpha. So if I work at 4 different levels, we my preliminary clinical report says that you are able to handle them much better. So I'm only giving some observation because you are a scholar. You may think that if this works, you may even start a project on that particular basis. So I'm only looking for observation because we are only on a clinical side. We can only give our observations. So we are finding colchicine as a IL-1 beta inhibitor responding in some unresponding cases. It start working. Then we are finding a combination of kalmake, which is the most bitter plant, and which is specifically working at the level of nuclear factor kappa beta pathway, K pathway. So there are now time has come for us to talk about different cytokines and give them a combination than to wait for monoclonal antibodies.
I think it's a very rational approach. What you're saying makes a lot of sense, and especially the use of leukotriene and the inhibitor is a very, very good idea. We haven't used it, but I have read about it. And also, there is a rationale by giving IL-1 beta, which is one of the major killers in this. But in COVID times, whatever you say, or maybe I agree, we should not make people to say that yes, this is
Absolutely, absolutely,
a
absolutely. These are observations.
therefore personal experiences are very good
Absolutely,
for you, and because you take responsibility. But if your patient doesn't get better with using this, I cannot take responsibility.
absolutely,
This is what I want
absolutely,
to
absolutely.
say.
So I'm only say the purpose of this platform is only lateral thinking, where we talk about experiences, we share experiences. We are not here to make any recommendation. We are not here to build up any consensus. But I'm only trying to say is in these platforms we share our experiences, which people should know, and they can start working on that particular thing with that.
I can give you two, three experiences, and we have published it two, three times in different forums, international publications. One is if anybody who has got fatty liver, say if you have 20 to 30% of the people will come with high AST ALT, and high AST ALT means it's a hypoxic state, and hypoxia is because of fatty liver. This guy who has high AST ALT, the mortality, the morbidity is high. So what you do is on day one, oh, his ALT is 300. It is not a hepatotropic virus. Corona doesn't get into the liver cell. It only stimulates maybe the ACE2 receptors on cholangiocytes to some extent on the liver hepatocytes. But if it is high AST/ALT, it should raise your ears. Number two, if the person is drinking alcohol or has obesity, he definitely above 45, he has stage 2 fibrosis if he is diabetic and obese. That guy is a high risk partly because of liver, because he is hypoxic all the time, and the moment you have the liver enzymes will not go 5 6 times, even 3 times rise may be risky. Number two. Number three, if somebody is already taking high dose of statins, don't reduce it. Do not reduce any other drug. Statins may be useful for your patients. Now, what we do for our liver patient, that is what limited experience I can of cirrhosis and others. If a patient comes, we will prioritize, stratify the patient. Bilirubin has gone above 3. His MELD score, which is a marker, this guy has a score of, let's say, 12 or 14. We'll give him plasma. Early giving plasma is extremely beneficial, at least in our hands, and maybe in some other hands also. What plasma does actually is gives you a amount of antibody that you require, as well as it removes the cytokine, excess cytokines, which can cause a tomorrow's fall in blood pressure. So I think there is an advantage in moderate, may not be very much in severe, and giving it in within first 3 days. So as a therapy, if you want me, and this has been a debate, some ICMR people, government of India, भाई ठीक नहीं है प्लाज्मा से कोई फायदा नहीं है. But on the other hand, many physicians, I mean, we when we the COVID started, we were having in plasma bank 20 to 30. requests a day. Now they are 50 to 60 a day. Not that we have said advertise, but we are saying some people may be finding it useful. But do not delay. If you have to give it, choose the time. If the IL-6 is high, if your CRP is high, and maybe lung is not very involved, plasma may be good. But if lung is getting involved, maybe steroids and others, good choice.
अगर हम लोग सपोज आई टेक द लिवर 37% सोसाइटी को आज की डेट में फैटी लिवर है इंडिया के अंदर में एंड they all of them will have a pot belly obesity. The marker may be that they have a baseline CRP maybe between 1 and 3 which have a low grade inflammation already. Do you think that because they have adipocytes उनकी cells का size बड़ा है, they have big cells in liver cells, and when they decompose they produce more interleukin 6, the number of their phagocytosis of the adipocyte or adipocytokines, that means cytokine produced by the adipocytes, they may not be able to clear. Therefore these patients will develop more systemic manifestations. Do you think that
Yes.
means system
Also, this is a severe mitochondrial injury. In
Yes.
fact, what it does is hypoxia, a mitochondrial injury, and membrane destabilization. So AST is very often higher than ALT. So remember, if AST is more than 2 times an ALT, this guy is a risky guy. You need to get in touch with a specialist. Number 2, if he has been drinking alcohol and has COVID or has diabetes which is uncontrolled, then it is a major problem. This is what we have seen, and there is a publication from Hong Kong that those who have got such have very worse prognosis. They get in fact much faster MI in 24 hours. Such patients. So fatty liver, alcohol, and severe COVID, cardiac, your area is more.
So is there a cutoff in fatty liver for COVID seriousness? Is there a cutoff?
For fatty liver, well, I
Fatty
would say
liver cutoff.
fatty liver grade 2, not grade 1.
Grade
Grade 2 and
Grade
3 certainly are high risk.
So coming back to long COVID or a post-COVID, I call them as post-COVID because the word post-COVID is virus is dead and whatever is left is post-COVID. People call them as long COVID. क्या कर सकते हैं? Fatigue, जैसे muscle pain, exhaustion, mental fog. We have not been able to find a solution.
The slight, maybe useful information. Long COVID is when it is lasting for about 6 months or so, although nobody has defined it well. But long COVID, we should use, maybe suggest, which 6 महीने पहले हुआ था, अभी भी नहीं ठीक हो रहा है. Or the second is post-COVID, which can be maybe next month, 2 months, or you get in again also. Now, long COVID is generally when people had fibrosis in the lung, and after virus is dead, but the lung doesn't get better. Their cough, their breathing, their even hypoxia doesn't get better. So we do not know how to manage. Very many studies, JAMA and NEJM have published, but the long COVID with that is a specialist area, and right now, as far as I know, no medicine. But fatigue, extreme, I have a colleague who got it. He says, I can't go to the toilet. I mean, he's a very young, bright, strong, physical guy, medical guy, but he cannot. Such severe fatigue. But high dose of vitamin C, which is an anode donor and a very good thing, and high dose of vitamin D, which is intrahepatic immune modulator. It is not anything else. Actually, it modulates the cells in the liver, the NK cells, and every processing. So C and D are some of those very good things. My own feeling, and that is a little personal, do not make it scientific, is that white butter, which has long chain and it has fatty acids, is very good in this. There is no substantial data. But recovery, because it makes your lactobacilli grow 20 times faster. So white butter, good lactobacilli, your gut environment is changed, and all your inflammatory markers come down. So this
What
is
about carnitine? What about L-carnitine?
Yeah,
Mitochondrial.
L-carnitine is very good, no doubt about it. L-carnitine, आप जो ये खाते हैं vinegar, Vinegar as propionic acid is very good for short chain butyric acid. They're very good, you know. So, but avoid using indigenous medicines, please. I cannot name and give you the numbers of people who are using indigenous herbal preparation and others for protection. My feeling is one should be very cautious in using them.
So you are watching Dr. Shiv Kumar Sareen, and we have been discussing about various lessons learned. We'll continue, but after a short break. And after a break, I'll also bring in Dr. K.K. Kalra, the former CEO of NABH. And so all three of us will interact, and if required, one or two questions also we will take from the viewers who are watching this program. Let's have a short break.
I will have to leave, Doctor.
You are watching Med Talks with Dr. K.K. Agarwal, and my another question to Dr. Shiv Kumar Sareen. And my question is very clear about vaccine. What is the current status of vaccine in the country? And if given a choice, which vaccine you would prefer for yourself? Dr. Sareen. Dr. Sareen, आप हैं क्या? Dr. Sareen, मनमीत डॉक्टर सरीन से पूछिए, 5 मिनट के लिए आएंगे.
Okay, sir.
Dr. Sareen has left because he had his own commitment. Dr. Kalra, आप कौन सा वैक्सीन लगवाएंगे अगर आपको लगाना पड़ा तो?
ये तो I think this time will tell when all the information is available.
कल वैक्सीन आ गया है मार्केट में, मान लो कल वैक्सीन मार्केट में आ जाता है, तो आज की डेट में जो इन्फॉर्मेशन अवेलेबल है वो इन्फॉर्मेशन अवेलेबल है.
Well, that is the आज की डेट में देखें तो information is little incomplete. Till complete information is provided, it's very difficult to decide the type of which vaccine should be used. I think maybe when the vaccine comes in the market, that time probably more information is required, will become there, to which will be better that time to decide.
तो कुछ 3-4 लोगों के सवाल ले लेते हैं और उसके बाद में हम आज के प्रोग्राम को खत्म करेंगे. मेरे सवाल हैं ग्रेट विनय कुमार जी, नमस्कार. Doctor, please tell what to do after getting scars in lungs after getting COVID negative. It's lung on base. प्रैक्टिस कर लंग्स के अंदर में तो जितनी आपने एक्सरसाइज कर सकते हो वही करो, इसके अलावा कोई चॉइस नहीं है. डॉक्टर साहब, प्लीज गिव जॉब टू रिस्पॉन्सिबल डॉक्टर. एवरी गुड डॉक्टर इज नॉट ए गोल्ड मेडलिस्ट. जॉब टू रीजनेबल स्किल्स. डॉक्टर, एवरी गोल्ड मेडलिस्ट इज नॉट गुड एंड एवरी गुड डॉक्टर इज नॉट ए गोल्ड मेडलिस्ट. विक्रम जी, समझ में नहीं आया मेरा, आप क्या इशारा कर रहे हैं? हैज नो वैल्यू, आपको गोल्ड मेडल मिला कि नहीं मिला, एज लॉन्ग एज यू कैन कम्युनिकेट टू द पीपल. हेलो सर, माय एल्डर ब्रदर इज टेस्टेड पॉजिटिव लास्ट संडे. ही इज हैविंग फीवर एंड कोल्ड. कुड यू प्लीज असिस्ट? 101 बुखार मतलब निमोनिया है, मिस नहीं करिए इसको. यस डॉक्टर कालरा, यू कैन कंटिन्यू.
हाँ जी सर.
Yes, Dr. Kalra, you want to interact for 5 minutes and then we stop.
Vaccine about already I have given. Uh, Nothing more than that regarding till all information is available. That time when it comes to the market, only then probably it will be easier to choose a vaccine, or maybe all type of vaccines which are available, which will be available in a month's time. Probably all may not be available in our country because of the so many
India,
logistic supply chain.
India, इंडिया में तो अवेलेबल तो होंगे वैक्सीन, द रीजन
हाँ,
भी बन तो इंडिया में रहे हैं,
तो
जब इंडिया
इंडिया में
में बन
नहीं
रहे
है.
हैं.
हाँ, till safety data is fully provided in the public domain, it will be, and no doubt most of these companies nowadays they're coming with efficiency of more than 90%. But what about the safety in the human data? Because some more time is required to assess the safety. Probably.
चलो, सेफ्टी का तो डाटा हम देखेंगे. आप लोगों के और लोगों के सवाल हम अब कर लेंगे. आज हम नमस्कार करते हैं, धन्यवाद करते हैं डॉक्टर एस के सरीन को जो वो आज आए. And I am also thankful to Dr. K.K. Kalra for being here and giving his opinion that if you really want to have a vaccine, wait and wait. पहले अवेलेबल हो, पहले DCGI उसे अप्रूव करे, फिर अवेलेबल हो. समटाइम्स बेगर्स कांट बी चूजर्स. पता लगा एक ही वैक्सीन इंडिया में अवेलेबल है, दूसरा अवेलेबल ही नहीं है. और हाँ, चॉइस होगी तो उस टाइम पे हम आज के एक सेशन में एक्सपर्ट्स को बुला के डिस्कस करेंगे, डिबेट करेंगे और उसके बाद में आप डिसाइड करिए. दैट्स ऑल फॉर टुडे. We'll be back tomorrow 7 p.m. with another show. Keep watching Med Talks with Dr. K.K. Agarwal. Namaskar.